Thank you, Graham, and thank you for the Prostate Cancer Foundation for inviting me to talk to you. One of the interesting things about pathology is it's sort of crusty and backroom and not many people know about it, but everybody knows about Gleason, and I think that everybody is very interested in what the Gleason score of their tumour is. Well, Gleason's changing, and that's what I want to talk to you about today. Gleason is a grading system, and grading is very important to pathologists and to oncologists. And I want to explain a little bit about it. Now, I know that there are people in the audience who understand everything about grading and Gleason, but I've got to deal with you all, and I want you to come away with having some understanding about not only Gleason grading, but also the new changes that are going to occur with respect to Gleason grading. So first of all, why do we grade tumours? Well, pathologists love to grade tumours. For every tumour, there's about 20 grading classifications. And the reason we do it is because tumours have heterogeneity. That is, that they look different in different areas. And one of the things we want to make sure is that we've got some sort of descriptor which allows our colleagues to understand what we mean. So if we provide a grade, we say it's a high-grade tumour or a low-grade tumour, which means that it looks less or more like the tissue of origin, and from that we can imply that it's going to behave in a bad or a good way. And that's really what grading is. It's a marker of how rapidly a tumour progresses. Don't mistake it with staging, which is how far a tumour has spread. One of the fourth-year exam questions is describe the difference between stage and grade, and about a third of them get it wrong. So I will be asking you questions later. The most important thing about grading is that it does predict outcome for a number of tumours. The prediction can be very strong, it can be very weak, and sometimes it can be non-existent. But with respect to Gleason grading, it's one of the strongest predictors there are. It's a very powerful grading system. It's survived in various iterations for over 40 years, and Gleason is a household name in the Prostate Cancer Foundation and indeed in the world of pathology. And finally, it does allow us to stratify outcomes with respect to stage and therefore optimise treatments for patients. So that's just a broad overview of grading. Now, with respect to prostate cancer grading, really it's no different to any other cancer. There are more than 40 grading systems, and they look at various parameters. And the parameters I've listed there are the overall shape of the tumour under the microscope, how irregular the nuclei are under the microscope, that's nuclear pleomorphism, the size of the nucleus, that's the component of the cell which is responsible for the production of proteins, or the central controller of the nucleus, the nucleolus, which can be big or small. And when you've got a big, prominent pink nucleolus in the middle of a nucleus, then you know that there's a lot of protein production going on. Mitotic rate, that means how often are the cells reproducing. And you see these lovely little shapes of mitoses where the spindles of the various chromosomes are splitting apart, and that's called a mitotic figure. And the higher the mitotic rate, obviously the faster the tumour's growing. And finally, just an overall marker of how rapidly the tumour is proliferating, and so is it forming glands, or is it going so quickly that it isn't forming glands and it's just forming solid masses. Now, when we get to talk about Gleason, you'll see that the overall architecture and the glandular formation versus solid is a particularly important component. So this is Donald Floyd Gleason. And Donald Floyd Gleason was a little man. He was actually even shorter than I. And he was a lovely chap. He was in Minnesota. He joined the army at the end of the Second World War, which is a good move if you're an American because you get free training. And at the end of the Second, well, he was young. You get free training, and you also get an ability to have free insurance. But it backfired on him because while he was on the reserve, he was called up for the Korean War, and he had to go. And he went along and then travelled back through Japan with his wife, where he took art lessons. And that will have some relevance later on. He then settled in Minnesota, and he was just a sort of small provincial pathologist until one day the Veterans Administration Cooperative Urologic Research Group was formed. And this was one of the earliest trials that looked at prostate cancer. And he was appointed the pathologist for this trial. And one of his roles was to grade the 2,912 patients, and he thought, well, this is going to be a bit of a problem. And he thought, well, the reason we're going to develop a new grading system is that all the grading systems that were in existence at the time were not reproducible, and you had to look at things under high power under a microscope, which is incredibly time consuming, and so it was literally going to take him years to grade all these tumours. So he wanted to come up with a grading system where he could just flick the slide under the microscope and say, aha, it's a 3. And so he looked at the various patterns that had occurred, and in about 200 cases he came up with a recommendation which was accepted by the group. And it was that the extent of differentiation in the pattern of the tumour growth was the most important. And in so doing, he recognised 9 patterns. And I'm grateful he's actually dead now, but he did make these pictures available to us. And these are his actual illustrations showing the 9 patterns that he recognised. And you can see going from 1 to 9, there is a loss of normal architecture. You know, the prostate gland histologically is a bit like the breast. It's a lump of fibrous tissue with a lot of glands in it. And you can imagine that looks pretty much like the prostate, but down here we've got masses of irregular, undifferentiated infiltrative cells, and that looks nothing like the prostate. So we're going from recapitulating the parent tissue down to no longer recapitulating the parent tissue. And he noticed that some patterns occurred together, that not every pattern occurred independent of another pattern. So he recognised that the 2 original patterns, 1 and 2, often and usually occurred separately, but there were 3 sets of related patterns, pattern 3, 4, 5, 6, 7, and 8 and 9. And so he grouped them. He grouped them into groups 1, 2, 3, 4, and 5, and they had these patterns in them. And these became grades 1, 2, 3, 4, and 5. And I'm not trying to educate you to be pathologists, but I want you to just have some idea of the terminology and an overall image of the architecture associated with each of these grades. There have been lots of amendments of the grades, and I don't plan to go through all those, but I just thought I'd give you a flavour of what Gleason originally described. So pattern 1 was, first of all, well-differentiated, small, uniform, close-packed glands. Not like an ordinary prostate, which has loose glands, but a nice little ball of close-packed glands. Pattern 2 was as for pattern 1, but there was some variation in size and shape of the glands, and they were perhaps a little more loosely arranged. Pattern 3 had irregular glands scattered throughout the tumour. Now, there were some other components in pattern 3 which we have now abandoned as pattern 3 criteria. First of all, there were individual cells. Well, this is now recognised as a highly aggressive form of prostate cancer and is now included in Gleason pattern 5, not Gleason pattern 3. And also that there were solid cords and masses. Again, this is a highly aggressive pattern, and this is now included in Gleason pattern 5. Gleason pattern 4 was just large, clear cells. This does occur in prostate cancer, but it is vanishingly rare, so rare as to not even worry about. I don't know how on earth he came across them, because I think my whole career, and I must have seen literally tens of thousands of cases of prostate cancer, I think I've only ever seen 4 of these. And then solid masses with showing a diffuse growth, which is a bit like the sort of solid cords and masses, and one wonders how he differentiated between them, became Gleason pattern 5. Now, I explained that he had taken art lessons in Paris, and we're very lucky that he did, because he actually drew this. And this is an illustration that is probably on the wall of most pathologists' offices all around the world. And this is an illustration of Gleason pattern 1, 2, 3, 4, and 5. And you can see that these are fairly uniform, that here in Gleason pattern 3, we've got ordinary but irregular glands. We've got glands that, these are called Cribriform glands. Now, it's a term I'm going to use. It's a solid mass with lots of holes in it, so the tumour looks rather laciform, and there's been some debate as to the significance of that, and that will become important as I carry on. Then we have these rather poorly formed glands which drift into 4. This is a typical Cribriform area here, and some individual cells which are drifting into 5, and 5 is just sheets, and cords and individual cells, and then we've got this strange collection here, which are Cribriform glands which have central necrosis, That's the fancy word for death, central cell death, and that's called chemidonecrosis. And chemidonecrosis is often diagnostic of cancer. It's interestingly enough, one of the diagnostic features of introductory carcinoma in situ of the breast. And certainly we get chemidonecrosis in high-grade Gleason pattern 4 adenocarcinomas. Now, Gleason recognised that many tumours had a variety of patterns. So you could have a tumour which was 2 and 3 or 3 and 4. And so what he did was he looked at this and he found that the mortality of mixed tumours was intermediate between that of pure grade tumours, and he found that the average grade correlated better with outcome than the highest grade or the lowest grade. So we now have 5 grades, and he developed what's known as the Gleason Score. He took the most prevalent grade and called it the primary pattern. He took the second most prevalent grade and called it the secondary pattern. He added them together. So we have a Gleason Score. So if you have the most prevalent grade is 4, the second most prevalent grade is 3, 4 plus 3 equals 7. The pathologists always add it up for the urologists. I'm sorry John's not here actually, because we know that most urologists can't count beyond 5. This then meant that he had a scoring system which ranged from 2 to 10. And you say, well, what if it was all 3? Well, you add the 2 3s together, so that's 3, 3, 6, or 2 4s, 4, 4, 8, or 4, 5, 9. And that was the Gleason scoring system, and it was established back in 1966. It went through several iterations with the major publications in 74, and Gleason wrote his last review paper in 1992 where he tweaked it a little bit, and that was the Gleason scoring system. Now, we also noticed that beyond having 2 patterns, there may well be a third pattern. But he didn't really know how to handle this, and so this was called the tertiary pattern. So if there's a tertiary pattern, it's always just put in brackets at the end, and you think, it might have an influence. So you might have a Gleason 3, 4, 7, brackets tertiary 5, in which case it probably will have an influence because you've really got a very high-grade tumour, albeit a very small component. So he said that a higher tertiary pattern should be reported. Now, what about validating the Gleason system? Well, first of all, there are sampling errors. First of all, if you look at Gleason needle biopsies and then you look at the resulting radical prostatectomy, there's only an exact correlation in 43% of cases. And what happens is most tumours are undergraded. What about as a prognostic indicator? Well, actually, it's a very powerful prognostic indicator. This is tumour which is detected clinically, and this is a small unilateral tumour. And you can see if you look at the Gleason scores, survival goes down the higher the score. And this is highly significant. And this is, in fact, one of the best grading systems there are. And this, you will notice, 10-year progression-free survival. Now, interestingly enough, one of the problems with Gleason is that 4-5 equals 5-4, because they're both Gleason score 9, and even more importantly, 3-4 equals 4-3. But if you stratify 3-4 and 4-3, you can see that if 4 predominates, it has a worse prognosis than if 3 predominates. And so what's happened over time is this has been split up, and we now call this 3-4 equals 7A, and 4-3 equals 7B. But more on that later when we come to the new scoring system. Gleason in 1974 really produced the definitive paper. As I said, it was added to in 1992. And when he did that, the majority of patients had extraprostatic disease. A significant number of prostate cancers were diagnosed, first of all, on transurethral resection of prostate or on rectal examination. In fact, most patients presented with metastatic disease. Since then, things have changed dramatically. We now have thin core biopsies, we have PSA testing, and I just want to underscore what John Lacey said. PSA testing is a godsend for every man. And so, as a consequence, most patients now present with low-stage disease. And the other thing that's happened is we've got these fancy stains that can stain the basal cells in glands. Only benign glands have basal cells, malignant glands don't. And so it's a great boon for pathologists if you look at the squitty little bit of tissue and you see a gland on it and you think, is this benign or malignant? Well, you just run a bit of high molecular weight cytokeratin on it and you know that it's malignant. And this has had the effect of showing us that a lot of lesions that were diagnosed back in the 70s and before as cancer are not. And as a consequence, Gleason pattern 1 and Gleason pattern 2 in needle biopsy is no longer diagnosed because we recognise that the majority of those lesions were probably benign glands. There's a study that's shown this through the Mayo Clinic. And this is one of the real problems that has hampered our recognition that prostate cancer is a serious disease, because a substantial number of lesions were diagnosed as benign. Obviously, the patients did very well. And so the naysayers amongst us say, well, this isn't really much of a problem of disease because a lot of the patients do well. Well, the reason they did was because they didn't have prostate cancer. We've now recognised that we can diagnose it accurately with these ancillary studies, and we don't have to rely just on morphology, which is important. Now, before you all run off to the Health and Disability Commissioner, let me tell you that this was years and years ago, long before even I started training in medicine. But it is a real problem because it still hangs in the literature, and we have this understanding that prostate cancer is a relatively benign tumour. So, in order to address these issues, the International Society of Urologic Pathology, which has a pretty stunning logo actually, that's the kidneys, the ureters, the bladder, the testis and the penis, convened a conference back in 2005 to look at issues relating to Gleason grading, and we really blew Gleason grading out of the water. This particular conference was under the chairmanship of Jonathan Epstein, who is the professor at Johns Hopkins, and it had a cast of about 99. Here's the Australasian contingent in the background, and some of you will know some of the players here. John Shrigley is a visitor. He's at McMaster University. He often comes out to New Zealand, and we've got Mahul Amin on the back from Cedars-Sinai talking to his stockbroker. And what we did then was we looked at the various criteria for Gleason grading, and we came up with a number of consensus decisions which we voted on. And we came up with a new grading pattern. And again, I'm not going to go through it in great detail, but basically we abandoned 1 and we abandoned 2. But unfortunately, pathologists are very sentimental, so you should diagnose it really. The true answer is you should never diagnose it. This is pattern 2, and you can see it's just extending to the edge, and you really don't know what's going beyond the edge of the biopsy, so you really can't call it pattern 2. Pattern 3 consists of discrete glands and little glands that had a cribriform pattern. Let me explain. First of all, here's the discrete glands. They're not connected. Again, they're not connected. And it's recognised that these have a good prognosis. Now, you can have these, and this is a typical cribriform gland, but we considered that it was appropriate that these would be considered pattern 3 as long as they had nice, smooth outlines. Pattern 4 were poorly defined small glands. This was a novel descriptor. And then finally, that it largely consisted of large cribriform glands. So we have these cribriform glands, and you can see from a pathologist's viewpoint, you think, look at this, you think, well, this looks a bit nasty compared to the other one because it no longer looks like the tissue of origin. You've got these cohesive glands here, and then you've got these cohesive glands which are actually showing some discohesion as well. They're starting to split apart because they've lost the proteins that cause the cells to bind together. And finally, pattern 5, it hadn't changed. It has chemedonecrosis, solid masses of cells or individual cells, and this is a chemedonecrotic area. It's got a cribriform area with necrosis in it. And so we rewrote the Gleason illustration. Unfortunately, I don't think it's as good as his, but the point was that we still included these rounded cribriform glands in 3. The other thing was that we had to acknowledge that tertiary patterns did have some importance. And so the whole of the grading system changed, and we included the tertiary pattern as the secondary pattern. So if it was 3, 4, 5, it now became 3, 5, 8, and we abandoned the 4. So this meant that everything was being upgraded, and that's exactly what happened. All the low-grade ones declined in populations, and the higher-grade ones increased. And in fact, 336 became quite unusual. Again, these are various studies that have shown that in this case, in 15% of cases, the tumours went from 6 to 7. And in our own study, the proportion of 4, which was a smaller component, declined, whereas where it was a greater component, it increased. So there was a shift to the right, if you like, and a lot of the 3s were reclassified as 4s. Now, the other issue is that the Cribriform pattern that we saw in 3 is actually very rare, these rounded ones, and it's always found in association with other sorts of pattern 4 Cribriform glands. And really the interesting thing was we felt that this was a bit of a paradigm shift architecturally, that you're going from a discrete gland to a solid mass with holes in it, and therefore it should be a different grade. And the feeling was that these should now be classified as 4. And so anecdotally, 3 was taken out and put down here, the Cribriform glands. And so this is the pattern that we had. Now, this had not been validated. First of all, the issues that came out of it with the Gleason scores had been validated by survival studies, that the opinions that we came up with in 2005 were anecdotal, and we needed to validate them. We had changed Gleason pattern 3 beyond 2005. We noted that the higher tertiary pattern did influence outcome, and therefore we included it. But most importantly, we now had a grading system which was 6 out of 10. So the patient goes along and to the doctor, and he says, because he's been on the internet, what's my Gleason score? And the doctor says, why, it's 6. And he says, what's it out of? 10. Oh, 6 out of 10. That's terrible. That's more than halfway up. No, it's the best you can get. And that just doesn't make sense, does it? So we felt that something had to happen. Interestingly now, grade 3, the acinar pattern of grade 3, has a good prognosis. 14,000 cases, no lymph node metastases. This is as defined. 5-year biochemical survival rate is very high, and lymph node metastases in other series, these are 3 different series, the lymph node metastases are very low. So we thought there has to be some changes. So 6 of us were appointed by the International Society of Urologic Pathology. I mentioned some of the names: Mahul Amin from Cedars-Sinai, myself, Lars Egervard, who's the professor at the Karolinska. The Karolinska is the institute that awards the Nobel Prizes. Jonathan Epstein from Johns Hopkins, Peter Humphrey from Yale, and John Shrigley from McMaster. And we convened a group of 126 pathologists from 29 countries and 30 oncologists and urologists, and we came up with a new grading system. And the grading system that we came up with is here. And you can see that what we have done is we have accepted, first of all, that Gleason pattern 3 does not have Cribriform structures in it. It just consists of acinar, or rounded little collections of cells that form glands. And if you have a tumour that is that alone, then it is likely that it will not be extraprostatic. And these are the patients who are going to do very well with active surveillance. So one of the requirements of active surveillance is that you have a 336 tumour, and the 336 tumour does not have any other component. Some urologists will take a small component of 4, and there are studies underway now looking at to whether or not 10% 4 is okay. And it seems that it probably is okay, because if you look at the survival curves, which I'll show you in a minute, 336 and 347 hang together. We then recognised that 3 plus 4 equals 7 and 4 plus 3 equals 7. It should be separated. But we also felt that anything that was Gleason Score 8, 3, 5, 4, 4, 5, 3, and bear in mind that these 3, 5 is inordinately rare, because you usually don't find 3 and 5 in the absence of 4, in which case it would be bumped up, because bear in mind that the tertiary score becomes the secondary score. And then finally, we lumped together 4, 5, 5, 4, and 5, 5. And if you have any proportion of 4 and 5, then this is going to be a rapidly proliferating tumour. And we put them into grade groupings, 1, 2, 3, 4, 5. This is now known as the ISUP grade, the International Society of Urologic Pathology grade. and it runs from 336, 347, 437, Gleason Score 8 and Gleason Score 9. Well, that's all well and good. It sounds good, doesn't it? But you need to validate it. And so we have here a survival study which was undertaken at 5 institutions of 17,000 patients. And these are divided according to the ISUP grades. And you can see, if you were going, this is called a Kaplan-Meier curve, and it's survival. Here's the time here, and here's the proportion of survivors down there. So if you're going to fabricate data, you couldn't actually fabricate anything better than this. This is almost the perfect Kaplan-Meier curve. It's so good, it's too good. And yet it's a wonderful example of how adjusting Gleason scoring really does provide meaningful data with respect to outcome. So you see patients with 336 or ISUP grade do very well. Patients who have ISUP grade 5 do rather badly, and this is over a long follow-up period. So this is now in the process of being published, and I'm pleased to say that we had a meeting. I'm on the World Health Organization work group for prostate cancer. We had a meeting in March. It has been accepted by the World Health Organization, and it will be published in the book next year. The definitive paper's coming out very soon, and it will be the international gold standard in terms of grading. And so, not to be outdone, we produced another little diagram, and you can see that we still have 1 and 2. You just can't stop these romantic pathologists. There was a lot of debate that it should start here, and of course it should start here, but there it is. And so we've just got simple glands, small irregular glands or cribriform glands, individual cells, solid masses of cells, or comedocarcinoma, and that's the simplified grading system. So I'll be handing out examination papers in about half an hour. Thank you for your attendance. That's all I have to say.